Well, hi. Hope that you're doing okay. Um, we've made it through the first couple of weeks of class and all the good stuff that comes with that. Recording the clinical connection video just to kind of show you what um, this clinical connection video is actually intended to help you kind of understand and prepare for that. Um, if you choose to do the SOAP note as your final summative assessment. Again, there's pros of doing it that way. That gives you a little taste of what it's like to do something that clinicians do. The reality is, I have to tell the grad students this all the time, is that clinicians do documentation. You're not getting away from it. Um, so you're going to do some sort of writing the rest of your life. Now, some electronic medical record system or electronic health record systems, so you'll hear the acronym EMR and EHR dropped. A lot of them are pre-made that you can do click boxes if you prefer. Um, so, I mean, this is part of it. So, again, I think that it's better that you learn some of these skills, but again, with an online class, and definitely not what I anticipated us doing this fall. I wanted to give you the choice of doing that or something else. So we're going to do just very briefly, I'm going to walk you through kind of an overview. We'll talk more about documentation. Um, we'll talk more about documentation and everything in Acquired. I'm teaching that course. I think it was officially announced. We're already having a plan for spring. So I think you'll have me in Acquired and we'll talk more about documentation in medical settings. So this is more of like a quick overview so you can feel supported for that project if you choose so to do it. Remember that by October 5th, I need to have an answer that you'll be doing um, that which assessment you'd like to do as your final assessment. But just to kind of educate you more, we'll kind of walk through. I am going to share my screen a few times, and I'm going to show you also what tools you have to use in that SOAP note if you choose to go that route. So here we go. All right, so clinical note writing in medical settings. So there's lots of different ways that people write notes. There's no wrong way to eat a Reese's peanut butter cup. Um, Kind of one of the most common formats. There's burp, there's DAP, but the probably most common one, the most traditional one, is still the SOAP note or SOAP. Um, some settings kind of rearrange these. Like, for instance, my mother-in-law is the director of home health services for a hospital system. And long story short, they actually invert that. They do more of APSO notes, or actually, I think they're doing APSIO notes, um, which you add an I standing for intervention. But we're going to stick to pretty simple. We tend to keep it simple for our students, keep it simple for us. And again, with electronic medical records and everything, SOAP is not the only way to do a note, but it is the most common way to do a note. So let's talk a little bit about what SOAP means. So SOAP stands for, the S stands for subjective. You'll often hear this referred to as case history in subjective, especially for initial evaluations. Now keep in mind, like, this is again for more medical based settings. So everything's a visit. Um, it's based on what you bill on whether it was an evaluation or treatment. You are going to write a SOAP note for an evaluation. So a lot of times people will call this the case history and subjective if their first visit is an initial evaluation. And so really still it doesn't change too much for evaluation versus treatment. It's basically, the reason why it's subjective is because it is coming from the subject, which in this case would be your patient. So again, and I don't want to make out that perception is a bad thing, because as a clinician, your perception is is part of your tools. But essentially, it's also coming from the patient or the caregiver or loved one's perspective, and there's no true way to verify this. You can request records all you want to, but you're not going to be able to know every single thing about the patient. You're relying on a lot of what they tell you. And so we not only take the information they provide us or that we find, but we also listen to other care team members, so nurses, physicians, also loved ones, moms, dads, brothers, sisters, teachers, if it's more educational based. Um, if they do include the history, which is becoming more common, it's not it's pretty common now for them to be organized by categories, to illustrate and describe the patient with a communication or swallowing disorder. So you may have a medical history list, and these are their diagnoses. You may have a social list that says they live at, they live at home alone, or they're married, how many children they have. Sometimes tobacco and alcohol use is put in social history instead of medical history, but it's still an important thing to consider. There are two things that you want to make sure that your subjective section kind of always addresses, I feel, especially if you're doing an initial evaluation. And the first is what we refer to as HPI, or history of present illness. I've also seen it referred to as history of the problem. So this is basically what indicates you need to see this patient. Why is it important to you? What medical diagnosis or history should you consider in the context of the session? So if they've had a right stroke and that's been confirmed and diagnosed, we probably want to include that. Do any other services or results, such as imaging? So say they went to see, we're in voice class right now. So say they went to see an ENT and they've been scoped already, and what were the scoping findings. That also helps you, especially in voice, kind of support the need for your services. And as I mentioned earlier, you might have an active problem list as well as past medical history here in the HPI. Some places, in some settings, go ahead and put past medical history as well as an active problem list. You also, it's becoming more and more common for people to put a list of medications, but that's usually put in a separate section. The second thing we want to see in a subjective component of a note are chief complaints or a description of the problem. You'll see that coded as CC, standing for chief complaint. So a symptom is something a patient reports. A symptom is not something that clinicians perceive or measure. It comes solely from the patient. So we want to know what the patient is, how they're describing the problem of, oh, I'm hoarse. I can't sing in church anymore. Those are symptoms. Essentially, they're a description of the problem. And so some places do problem lists from the patient, but keep in mind that really the chief complaints or what they're complaining of are symptoms coming straight from the patient. The next is the objective, which the clinician that's doing the visit tends to care a lot about, but nobody else does. So it's called the objective session because, again, we like to think that we're objective in what we see and do. I also like to think of the objective section as what was observed, what could we actually demonstrate or prove what was done, and then what was the result of that. We also like to think of why we're there. So basically, the objective section answers the questions what was done and what was the result. And it again includes your procedures and the measurements acquired that address, if it's a therapeutic visit, then the therapy goals. You also want to maybe occasionally mention the purpose of the visit. I'll illustrate that to you shortly. Um, you want to be sure and talk about two things in your objective section. One being procedures. So if it's an evaluation, what tests did you use? If it's a treatment session, what intervention was used? What strategies? How do you show that it was a skilled service? Why did they have to see a speech language pathologist? And then the data, the results of those tests and tools, and any observations that you have. Again, we tend to care a lot about the objective section, and then really nobody else does. But probably your most important part of your note, and the one that I think is the hardest to learn how to write, is the assessment portion. So this is why assessment and evaluation are two different things. Evaluation fits into assessment. You are constantly assessing. You are constantly thinking about, did my patient respond to what I did? If it's an initial evaluation, you might think about diagnosis and severity. It's becoming more and more common in medical settings for there to be an assessment and a problem list of assessment. Number one, dysphonia, and then kind of what are your impressions about that dysphonia and what are you going to do about it. But really, you're looking at what was the response to services, and then if it is an evaluation visit, your diagnosis and severity with justification from both subjective and objective sections. We shouldn't just rely on what we did. We need to be listening to our patients. Prognosis, ultimately, what is working and what changes benefited the patient. What is their prognosis? How are they doing? And then finally, plan. If it is an evaluation, you need to outline that plan of care, including therapy goals. If it's treatment, what are you going to change and what are you going to do next time? And it's also not uncommon to put your recommendations and follow-up consultations and as you really. So again, the plan is pretty A, B, C. Assessment, you want big picture, but it takes the most art to write. Objective, what did you do and what was the data? And then subjective, what is your patient telling you, and who is the patient, who is the person sitting across from you? So to kind of show you and illustrate, I'm going to share my screen again right here. And here is an example of a voice patient I saw in our clinic, and I've redone it more to follow a SOAP note. And so again, this format and this template will be uploaded. You can't do all this. This is an example from the real world again. But you'll notice I had my identifier. Again, most places have little headers of what is their name, date of birth, gender, etc. But here's my history of present illness. You can see that I've described who he is, why he's being referred to me. I talked about that the ENT was there, etc. And then I summarized his chief complaints down here and what he was telling me. I even included what his goal was for intervention. And then an objective, here it is. Today's objective was to complete a comprehensive diagnostic VOS evaluation, right? And then some little details to help out. These are codes. Again, you're not expected to go to this level. I just felt that it was important to show you. But here's my data and the tools I used. Again, here's I scoped him. So here was my summary of my scope and the parameters there. And then it is becoming more and more common, again, like I said, with assessment, they'll do their diagnoses or their problems that the clinician, be there a doctor, a speech therapist, a nurse, a dietitian, and then underneath each diagnosis, they'll put their plan or recommendations. I've done a little bit different, but I did put assessment and plan together. So there's my diagnosis and why I feel that he has those diagnoses, my recommendations, and then the therapeutic goals, as well as some patient education. But that just really kind of highlights the major things that you're going to be expected to do if you choose to do the SOAP note version. Now, the two things I will expect you to do is to use a patient-reported outcome measure as well as auditory perceptual evaluation. And so that's part of the content of this week's lecture that helps, or this week's unit that kind of informs you on which to do. So we're going to do a quick stop share, and I'm going to show you the CAPE-V. And again, this will be posted. The CAPE-V, what you do is you follow the directions. What's great about the CAPE-V is that it provides directions for what you're supposed to do. It's standard information. You basically record someone's voice, and then you'll follow these stimuli, and then you'll rate the voice on this form. Looks like this. And I'm going to see if it works out pretty well. If not, I may have to do a separate video, but we'll look and see. So hold on a moment for me. You'll have to pardon my messy desk. Nope, it looks like it's not going to work. It looks like it is only identifying me. So we'll do it this way instead. Good attempt, poor execution, or poor attempt with the best of intentions. Let me pull up something else. Let's do So here we go. So this is the Cape V. I'll post this on WT class. What you do is you record the patient's voice doing these tasks. And then what you do is you take a ruler. Once you're listening to the speech sample, you put a little mark on the line with a pencil or pen. This is what we call a visual analog scale. You circle whether it was consistent or inconsistent, or you can also enter in other parameters. So this one does roughness, breathiness, strain, and pitch and loudness. And what you do is it's on a 100 mm line. So what you would essentially do is take a ruler, and you would use the centimeter side, measure the line, and then convert that. Instead of it being 100 or 10, it's 100. So for example, if it's 5.5 centimeters, it's 55 millimeters, right? I'm going to look and see if there's more information and a better tutorial on how to do this. But there's also a video of using the iCapeV, which is a computer program that we have, that you can do it on a computer. Of course, you have to have the special equipment to be able to do it. So again, like you would measure each line and put that over here, and that's your results. So this is our gold standard in voice. This is what you want to use. This is what you want to do is auditory perceptual. And this is a standardized tool. So it gives us nice, pretty numbers that insurance cares about. The other tool that you have to use is what's known as the VHI. And it is a patient-reported outcome measure that is kind of, again, it's the one that's used the most. Just a second. I'm going to screen save that one. Yay. It looks a little bit something like this. I will post, again, this as well. This is a patient-reported outcome known as the VHI. And so what you do is literally it's a questionnaire to give the patient. You give it to them, they fill it out, you calculate the numbers, and you put it in. Basically, anything under 20-ish is within normal limits. 20 to about 40, 50-ish is mild. 50 to definitely 60, 70-ish is moderate. And then anything above that is pretty much severe. And again, I want to emphasize that I'm not expecting you to be perfect. I want you to, if you choose to do this as your final semester grade or final semester exam assessment, because again, this isn't an exam, it's a project. It's really for you to get familiar with doing these clinical skills. I understand that a lot of you haven't done anything clinical yet. That's what you'll do in the next semester. But I want to emphasize, do not be intimidated by this if you want to do it. The beauty of this is that you're here to learn. You're not here to get it 100% right. So especially this part of your eval of your note should be super simple, because this is going to come straight from the patient. And then your evaluation for your Cape V, your auditory perceptual, that'll be all right too. So I hope you find this video helpful. Again, I may demonstrate and post another video to help you out. But that's our clinical connection for this week, is for you to kind of understand that doing these clinical methods, we have to document them. We don't get a chance to just say that we did it and that's good enough. So again, as you're thinking about the material and whatnot, the point of doing the SOAP note is to get you ready to do that actual responsibility and duty. So anywho, hope that you're doing great. Have a great week, and we'll talk to you soon. Bye-bye.